Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, Marcus at Home welcomes Dr. Parminder Judge and Dr. Doreen Zhu in Oxford, England, United Kingdom, in order to look in early 2025 into the future of nephrology and to discuss aldosterone synthase inhibitors as a potential new drug class for kidney protection in patients with chronic kidney disease, focusing upon their EASi-KIDNEY trial. The study design paper of EASi-KIDNEY, which has been published a few weeks ago in Nephrology Dialysis Transplantation, has been selected by NDT's editor-in-chief, Dr. Anders, and by us as our NDT paper of the month for a detailed Marcus at Home discussion. So, dear Parminder, dear Doreen, thanks so much for joining us. Dr. Parminder Judge is a senior clinical research fellow based in the Renal Studies Group at the Clinical Trial Service Unit and Epidemiological Studies Unit, CTSU, and an honorary consultant in the Oxford Kidney Unit in the Oxford University Hospitals. Her previous research works include the UK HARP-III and EMPA-KIDNEY trials. She is the co-principal investigator alongside Dr. Will Herrington for the EASi-KIDNEY trial, which is testing the aldosterone synthase inhibitor vicadrostat in combination with empagliflozin in patients with chronic kidney disease. Dr. Doreen Zhu is an academic clinical lecturer, also based in the Renal Studies Group at the CTSU and in the Oxford Kidney Unit. She was a clinical research fellow in the EMPA-KIDNEY trial and is now joint UK representative for the EASi-KIDNEY trial with Parminder Judge. And we are blessed to have Professor Johannes Mann from Erlangen, Munich in Germany as a guest editor tonight. Dr. Mann is the doyen of clinical research in cardiorenal medicine, and results of his pivotal clinical trials form the backbone of our evidence-based clinical work in nephrology, hypertension, and also in cardiology. And pars pro toto, I only mention the FLOW trial, which Dr. Mann discussed few hours after its publication in the New England Journal with us at Marcus at Home in May 2024, and which has been selected by us as our top nephrology paper of the year 2024. So thanks so much again, and we are looking forward to follow your presentations.
Okay, thank you for that kind introduction. I'm going to be talking about advances in nephroprotection. I have no personal disclosures, but there is a grant from Boehringer Ingelheim to run the EMPA-KIDNEY and EASi-KIDNEY trials. So the treatment for CKD is aimed at slowing the progression of kidney disease, and this has been limited to the use of renin-angiotensin system inhibitors, or RAS inhibitors, for many years. However, this landscape has changed in the last decade and has evolved rapidly with the discovery and availability of new drugs which have been found to be effective against CKD. So first of all, SGLT2 inhibitors. So there has been a fantastic amount of high quality randomized data on SGLT2 inhibitors in diabetic, cardiovascular, and kidney disease populations. And we've now had a serial replication of findings. There are 13 large placebo-controlled trials, all of which are landmark in their own right. Many patients have been from non-CKD trials, particularly those in heart failure, including patients with decreased eGFR. And there have been 4 dedicated CKD trials of over 25,000 patients, including 20,000 with diabetes and around 5,000 without diabetes. Now, the initial SGLT2 inhibitor trials in the CKD populations prioritize the study of patients with proteinuric CKD with diabetes, but most recent trials, in particular the EMPA-KIDNEY trial, included a broader range of patients with lower eGFR and lower levels of albuminuria. And when you pool all of this data together, compared with placebo, allocation to an SGLT2 inhibitor reduced the risk of kidney disease progression by 37% overall, and there were similar risk reductions in patients with and patients without diabetes. When you just take the 4 CKD trials, the relative risk for kidney disease progression was similar when analysis was separated by primary kidney diagnosis. In the 4 trials, including patients with diabetic kidney disease, SGLT2 inhibitors reduced the risk of kidney disease progression by 40%. And data from the patients with non-diabetic kidney causes of CKD were available from the DAPA-CKD and EMPA-KIDNEY trials, so 2 of the trials. And here, SGLT2 inhibitors reduce the risk of kidney disease progression by 30% in patients with ischemic and hypertensive kidney disease, by 40% in patients with glomerular disease, and by 26% in patients with other or unknown causes combined, although we appreciate the 95% confidence intervals were wide. And when the glomerular diseases were further divided into disease subcategories, there was no evidence of heterogeneity between patients with IgA nephropathy, focal segmental glomerulosclerosis, or other glomerular nephritides. And data on reported acute kidney injury were available from all included trials, and compared to placebo, allocation to an SGLT2 inhibitor reduced the risk of acute kidney injury by 23% overall, with similar reductions observed in patients with diabetes and patients without diabetes. Now, this is another meta-analysis of nearly 50,000 patients from the clinical outcome trials of SGLT2 inhibition in patients with type 2 diabetes at high risk of cardiovascular risk or with chronic kidney disease. And this demonstrated a 16% reduction in the risk of hyperkalemia, which was defined as serum potassium of greater than or equal to 6 millimoles per litre overall. And there was also no increased risk of hypokalemia either. This is particularly relevant because this could be a particularly attractive advantage of combining SGLT2 inhibitors with medications such as RAS inhibitors and other drugs that affect the aldosterone pathway, because it could mitigate the observed hyperkalemia associated with those medications. Now, SGLT2 inhibitors are not without, the risk of adverse events. There is definitely almost fourfold increase risk of mycotic fungal infections and a small excess risk of urinary tract infections, about 7 to 8% when you look at the meta-analysis. However, this figure really showcases the estimated absolute rates and benefits and harms of allocation to an SGLT2 inhibitor versus placebo. And treatment for 1 year of 1,000 patients with chronic kidney disease and diabetes with an SGLT2 inhibitor is estimated to result in 11 fewer patients developing kidney disease progression, 4 fewer patients developing acute kidney injury, and 11 fewer cardiovascular deaths or hospitalization for heart failure. And it will also cause, however, 1 episode of ketoacidosis and around 1 lower limb amputation. And there are corresponding similar benefits in patients without diabetes and with chronic kidney disease. So I think it's safe to say that in the studied populations, SGLT2 inhibition safely seems to reduce the risk of kidney disease progression, also acute kidney injury and hospitalization for heart failure, irrespective of diabetes status, and the absolute benefits do substantially exceed the harm in the studied patients with chronic kidney disease to date. Now I'm going to talk about the non-steroidal mineralocorticoid antagonists and the new data that we have available here. So just a reminder, so we've had RAS inhibitors since 2000s really, and those are medications such as ACE inhibitors like ramipril or ARBs such as losartan and irbesartan. Now further down this renin-angiotensin-aldosterone system is where aldosterone acts on the mineralocorticoid receptor. And this is where medications such as spironolactone and finerenone that block the receptor work. Fidelity is the meta-analysis that pulled data from the 2 large trials of finerenone. And this showed that there were significant benefits in lowering cardiorenal risk. And this is important because prior trials of dual renin-angiotensin system blockade actually failed to show cardiovascular or kidney protection amongst patients with chronic kidney disease and type 2 diabetes. So this also suggests that there's the way in which renin-angiotensin-aldosterone system is blocked is important. And the fidelity analysis suggests a strong effect of MR overactivation in the pathogenesis of both the cardiovascular disease and the chronic kidney disease progression in patients with CKD and type 2 diabetes. And the 2 points highlighted here from the meta-analysis are a risk reduction in the hospitalization for heart failure by about 22% and also kidney failure itself. Now, since then, a new trial has recently been reported for fine arts. And when you pull all of this data together, this was called the fine heart pooled analysis. This robustly showed that finerenone reduces kidney composite outcome, and it's driven mainly actually by the benefits observed in the 2 previous trials, so Fidelio DKD and Figaro DKD. However, it did fail to show a significant reduction in the primary outcome of cardiovascular death. The new included trial was fine arts, and it enrolled a different population. So it enrolled a primary heart failure population with some coexisting kidney disease, but relatively low levels of albuminuria. So CKD progression was over a relatively short follow-up and somewhat difficult to evaluate. And finally, I'd like to discuss the glucagon-like peptide 1 receptor agonists and what data we have available here. So FLOW was a really exciting landmark trial, and it demonstrated that allocation to a low dose, so 1 milligram weekly subcutaneous dose of semaglutide versus placebo over about 3.4 years led to a 24% lower risk of major kidney disease events of death from kidney-related or cardiovascular causes. And these results were consistent across the range of pre-specified sensitivity analysis and were also broadly consistent across pre-specified participant subgroups. And to complement this, the SELECT trial also has some suggestion that semaglutide may have nephroprotection. So the SELECT trial demonstrated that allocation to a higher weight loss dose, so this was instead of the 1 milligram dose, it was the 2.4 milligram subcutaneous weekly dose of semaglutide versus placebo over this time 2.8 years, led to a lower incidence of the composite kidney outcome. It was 1.8% versus 2.4%. And this was in actually a huge population, so over 17,000 patients who were overweight or obese with cardiovascular disease, but without diabetes. And there was also no significant heterogeneity in this treatment effect in any subgroup. So with this in mind, the chronic kidney disease management guidelines, because of all these new amazing high quality randomized data that have now been available, they were updated in March. And you can see here that the renin-angiotensin system inhibitors and sodium glucose cotransporter 2 inhibitors are really frontline now. So they should be prescribed in most of our patients who can tolerate it in order to reduce the risk of kidney disease progression. In addition, statin-based regimens lower low-density lipoprotein cholesterol and will reduce the risk of atherosclerotic disease. Now, the guidelines were actually updated before the FLOW trial was reported. So in our opinion, actually, we should update this even now, and semaglutide and finerenone should also be considered alongside these other first-line treatments for certain types of patients, and that is patients with chronic kidney disease, with albuminuria and type 2 diabetes, alongside these other first-line therapies because of the new data that's available, even since the guidelines were updated. So in summary, high-quality randomized data in nephrology has led to increased medical therapy options for the CKD population. We have 4 good treatments for nephroprotection, so RAS inhibitors, SGLT2 inhibitors, the non-steroidal mineralocorticoid receptor antagonist finerenone, and also semaglutide. They have different and potentially complementary mechanisms of action. RAS inhibitors, SGLT2 inhibitors, and statin-based therapy is now the standard of care for most patients with chronic kidney disease, and they provide kidney and/or cardiovascular protection safely. For those patients who have got albuminuric chronic kidney disease and type 2 diabetes, they may also benefit from the non-steroidal mineralocorticoid receptor antagonist finerenone or semaglutide. Thank you.
Thank you very much, Doreen. So moving on to aldosterone synthase inhibition and the EASi-KIDNEY trial. So these are my disclosures. I don't have any personal disclosures, but the University of Oxford was provided with a grant by Novartis and Boehringer Ingelheim to perform the UK HARP-III, EMPA-KIDNEY, and now the EASi-KIDNEY trials. So as Doreen's already highlighted in her talk, for many years, the only treatments that we really had to target the aldosterone pathway have been renin-angiotensin system inhibitors. But more recently, we've also had the advent of the mineralocorticoid receptor antagonist, finerenone, although for many years we have had steroidal MRAs such as spironolactone and eplerenone available to treat particularly hypertension in our patients. But now there is a new class of agents, these aldosterone synthase inhibitors, which work slightly more proximally in the pathway and act on the enzyme aldosterone synthase, which is responsible for the production of aldosterone. And the hope is that in targeting the inhibitor that's responsible for the production of aldosterone, rather than the mineralocorticoid receptor, that we may be able to have an impact on a phenomenon known as aldosterone breakthrough, or the effects of excess levels of aldosterone or excess activity of mineralocorticoid receptor. And there's several different agents that have been developed and tested to date. Those include baxdrostat, lorundrostat, and most recently vicadrostat, which was previously known as BI-690517. And these have all been shown to directly and more specifically inhibit aldosterone synthesis, and I'll come on to each of them in a moment. So the first agent I'll discuss is baxdrostat, which was tested in about 250 participants with treatment-resistant hypertension in the Bridge Hypertension trial, and the results were published about a year ago now in the New England Journal of Medicine. And this trial tested 3 different doses of baxdrostat over a period of about 12 weeks, and the primary outcome was the change from baseline to 12 weeks in systolic blood pressure. And what you can see from each of these graphs here, that in particularly regards to the primary outcome, that systolic blood pressure was significantly and substantially reduced as compared with placebo, with increasing doses of baxdrostat. But likewise, also the levels of diastolic blood pressure, which was a secondary outcome, were also reduced quite substantially. And in further secondary analyses looking at the effects of the change in blood pressure by week over the time course of the trial, these blood pressure lowering effects were maintained with each of the doses of baxdrostat. So overall, the drug was shown to be highly efficacious and pretty safe too. So moving on to lorundrostat, so this has been tested in the Target Hypertension trial, and the results were published in JAMA about 18 months ago now. And this trial recruited a slightly smaller population of participants of about 167, with an additional exploratory cohort of about 38 patients with who were deemed to have unsuppressed plasma renin activity. When we look at the primary outcome, which was again change in blood pressure over the course of the 8 weeks of the trial, we can see that the blood pressure reduction compared with baseline and placebo corrected was substantially greater in individuals treated with the various doses of lorundrostat as compared with placebo. And even in those individuals with unsuppressed plasma renin activity, they had a similar substantial reduction in blood pressure. And again, the drug was well tolerated with no significant adverse events reported. So moving on to the third drug in this new class, vicadrostat, as I mentioned, previously known as BI-690517. And this drug has been tested in a trial that was published in The Lancet earlier this year. And this was a CKD specific phase 2 trial. It recruited nearly 700 participants, which about 2/3 had diabetes and about 1/3 without diabetes. And mean GFR was around 50 with about 400 milligrams per gram of albuminuria. Participants were initially randomized to empagliflozin or matching placebo, and then after a period of 8 weeks, they were then re-randomized to one of 3 doses of BI-690517, either 3, 10, or 20 milligrams, and followed up for a period of 14 weeks for a primary outcome of change in urine albumin-creatinine ratio from baseline to 14 weeks. Important other outcomes in this population included changes in kidney function, blood pressure, and effects on potassium, as well as aldosterone and cortisol. And what the graph here shows is that the BI-690517 with increasing doses was associated with significant reductions in albuminuria of nearly 40% with the 10 and 20 milligram doses. And we know from previous meta-analyses that a reduction in albuminuria of greater than 30% is deemed to be clinically meaningful. So this is sort of very exciting results if they could be borne out sort of long-term hard clinical endpoints. And the trial also showed that when we look at the effects in combination with empagliflozin, so these results just show the effects of BI-690-517, but when you add in empagliflozin to the BI-690-517, that there appears to be a synergistic effect with slightly greater reductions in albuminuria up to nearly 47%. So there are several other trials ongoing that are testing these ASIs in slightly different populations. So there's Bax hypertension, there's Bax duo, and that's looking at vicadrostat and dapagliflozin in combination in about 2,500 participants. And they're looking at a change in EGFR over 2 years. But there are also trials in other populations underway, and this trial, EASi-HARP-HF, is studying vicadrostat in participants with heart failure with preserved ejection fraction, and its recruitment is underway. The trial aims to recruit 6,000 participants with NYHA class 2 to 4 heart failure and a left ventricular ejection fraction of greater than 40% or more. And it's testing vicadrostat versus placebo on a background treatment and standard of care of empagliflozin in all participants, with a primary outcome of cardiovascular death or hospitalization for heart failure. So finally, moving on to the EASi-KIDNEY trial. So this is the trial that I'm most closely linked with. And this trial is looking to recruit patients with chronic kidney disease at risk of progression. And I'll come back to, on the next slide, how we define that. And we're looking to recruit 11,000 patients. So this is no mean feat, and this will be the largest ever trial to be performed in a CKD population. So we will be recruiting patients with type 2 diabetes and kidney disease, and we term them those individuals stratum 1, of whom we will recruit about 4,800 participants. And then we've also got, we will also be recruiting participants without type 2 diabetes, and we term those stratum 2, and we're recruiting about 6,200 such participants. So the intervention that we're testing is the ASI, vicadrostat versus placebo, but all participants will be provided with empagliflozin as a standard of care on a background in addition to RAS inhibition where indicated and tolerated. So even if a participant is not taking a RAS inhibitor, as long as that's documented that there is no indication for that, those individuals will still be eligible to participate. The trial is event-driven and will continue until about 1,070 primary outcomes have been collected in each stratum separately, and each stratum is powered at 90% power at a two-sided alpha at 0.05 to detect an 18% relative risk reduction in the primary outcome. So the primary composite outcome is very similar to the EMPA-KIDNEY primary outcome, including kidney disease progression, which is defined as either progression to end-stage kidney disease requiring dialysis or a kidney transplant, or death from essentially untreated kidney failure, or sustained decline in EGFR of 40% or greater, or a progression to a kidney function of less than 10 mL per minute per year. In addition, the other side, the composite cardiovascular component is cardiovascular death or hospitalization for heart failure. So how are we defining CKD at risk of progression? We're using the same criteria that we used in the EMPA-KIDNEY trial, which is local laboratory results recorded at least 3 months prior to the screening visit. And those individuals with an EGFR of 20 to 45, or those with an EGFR of 45 to 90 will all be eligible, but those with the higher EGFR at screening will also need to have a degree of albuminuria, which puts them at risk of progression. So in order to perform a trial of and recruit 11,000 patients, we need to go much bigger and broader than EMPA-KIDNEY. And this time we're going to about 20 countries in North America, Latin America, the EU, India, the Far East, and Australia and New Zealand. So where are we up to with EASi-KIDNEY? So I'm delighted to announce that the first participant was recruited globally for the trial, but here in the UK, in Oxford, at the end of August this year. Since then, we've now started recruiting participants in the US, Germany, and Malaysia, and we've got several other countries coming on board. And as mentioned by Gunnar at the start, the trial rationale paper is now available online since the 12th of November on the NDT website. So in summary, targeting the aldosterone pathway has been shown to be beneficial with finerenone, and has been shown to have beneficial kidney and cardiovascular effects. Non-steroidal MRAs such as finerenone are now becoming the standard of care in patients with type 2 diabetes and chronic kidney disease. But this is a limited population, and we do not, as to date, have the data that shows that these treatments are also equally beneficial in people without diabetes. So there is clearly an unmet need to test targeting this pathway in those without diabetes, those with lower levels of kidney function, and certainly those with much lower levels of albuminuria. And the aldosterone synthase inhibitors provide an opportunity and also an alternative strategy to target this pathway with the potential to reduce the risk of kidney disease progression and improving cardiovascular outcomes in people with CKD. And there's several trials ongoing testing ASIs in both kidney and cardiac diseases, of which EASi-KIDNEY is just one of them.
Thank you very much, Professor Judge and Zhu, for these wonderful presentations. They're very clear, and we will be delighted to show them to our audience. And because beginning from the first talk till the last one, I think there will be a lot of insights for our audience. But now we are also very excited to hear the first thoughts of Professor Mann.
First thoughts. Well, I was kind of overwhelmed by the first talk of Doreen, who covered in exactly 13 minutes more than 30 years of intensive clinical research, and quite appropriately so. I'd like to mention first that there were a number of trials, also very informative, that were not successful, showing no benefit, particularly on a lot of trials on DPP-4 inhibitors and on insulin and on sulfonylureas. So if we think of treating patients with diabetes, I think we should also, let's say, commemorate the drugs that lower blood sugar or glucose, but do not alter outcomes. So that what came first to my mind. Second, what came to my mind also in relation to both talks is the necessity, in my view, of implementing the data that we have and the drugs that we have, and for easy implementing, combining the drugs. So I hope that in EASi-KIDNEY, you do not use two pills, but a single pill, which combines the aldosterone synthase inhibitor and the SGLT2 inhibitor, because as I was also part of trials that looked at these single pill combinations or fixed dose combinations. There's a third name, which is polypill. Anyway, what it means is, if I look at the patients that I've seen this morning in the clinic, many of those patients definitely need pills that combine several agents, particularly in nephrology. If you think of a patient with heart failure and kidney failure, it is of paramount importance for compliance, and therefore also for getting the benefits on the road, so to say. So this is the second thought. Third thought. First was, what a wonderful talk, 13 minutes, a lot of work. Second was, think of the trials that did not show benefit, but are still used. And third, think of a polypill approach. So my question would be, in EASi-KIDNEY, are you using fixed dose combinations or not?
Yeah, so this is a great question, Professor Mann. So we are not, and I'll give you the explanation as to why in just a moment. So in the heart failure trial, EASi-HF, they are using it's not a poly pill or a combined pill. They're essentially it's still 2 pills, but they're both being given together from the outset. However, as you'll recall from my slide, part of the kidney outcome, composite outcome, is a 40% decline in kidney function. And we know, although I didn't present the data here, that drugs that target the aldosterone pathway do have are associated with an acute dip in kidney function of about 2 to 3 mils, is what was shown in the phase 2 EASi trial, and that's in addition to the 2 to 3 mil reduction in kidney function with an SGLT2 inhibitor. In view of this, we're having to take a staggered approach to initiation. So the empagliflozin will be started initially, and then after a period of at least 8 weeks of running, participants can then be randomized to the ASI or placebo because of the potential for having a large hemodynamic effect and drop in kidney. And because this is part of our primary outcome, we don't want to have a very large dip, or also large numbers of reports of acute kidney injury. So for those reasons, we're not giving a combined pill, but ultimately the intention is that it will be a combination pill. So does show both in the heart failure population and or in the kidney disease population to be beneficial, then longer term it will be a single pill that will combine the 10 milligrams of empagliflozin, and also I didn't mention, but it's the 10 milligram vicadrostat dose that's been selected for EASi-KIDNEY. So it would be a combined pill. So ultimately you will be able to have a combined pill, which will reduce that burden for patients.
And then thank you for your other comment as well about not mentioning. You are absolutely right. There were significant numbers of studies between kind of the 2000s and when the SGLT2 inhibitor trials first started to be reported. But all of them, as you said, sadly didn't show any nephroprotective benefits. There were actually significant trials that were also hugely significant and showed kind of cardiovascular protection. So, for example, the blood pressure lowering trials such as SPRINT, and also the statin-based trial. So SHARP was actually at that point the largest trial in the CKD population that did change our clinical practice and show significant cardiovascular benefit. But for the purposes of keeping this talk to time, I just focused on those with the positive kidney benefit. So I didn't even mention those with the cardiovascular benefit, which actually we would prescribe as clinicians all the time, because that's equally as important to our patients as reducing kidney disease progression. So I think it's really important that we do discuss this as well.
Yeah, when we design those trials, I hope you can agree, we have to design it in a way that whatever the result is, it will be of clinical importance. So coming back to our own studies, I mean, the on-target trial certainly had a hypothesis that was not borne out by the trial, but the data, namely that a combination of several drugs that inhibit the renal system is not useful and is producing harm, that
Absolutely.
came into the guidelines and has probably saved a lot of lives, as well as would be a positive trial if implemented. Yeah.
Absolutely.
Yeah, completely agree. And if we don't do those large trials, then we won't generate that important data. I think nephrology has suffered for many years from inertia to doing trials, and clinicians not having equipoise and sort of being concerned, having the feeling that their individual method of treating patients is correct. And I think we have to follow the example and the lead of the cardiologists who've done these large outcome hard endpoint trials, and without which we wouldn't find that some of these interventions that we do trial are harmful, like combination of RAS inhibition, dual RAS inhibition, like medications like also been proven to be harmful. But obviously some of these treatments are now being repurposed for certain populations. But broadly, if we didn't do these trials, we wouldn't be able to show that that not all of our interventions are safe or appropriate.
Yeah, therefore it's very important to do large outcome trials,
Absolutely.
also to have a safety signal, particularly for rare events, for instance, mortality. Yeah. In previous times, I mean, I remember the times when we argued at the bedside about pathophysiology this way and this way. It's still important, but if it's the only basis of our thinking, it will not get things forward. And therefore, the EASi-KIDNEY trial is certainly, just by its pure size, will be producing significant results, whatever the outcome will be.
Absolutely,
and remember that about half of our trials, the hypothesis that we test will not be borne out.
We agree.
Yeah, absolutely, and that's the whole. That's one of the key ideas behind having the two-stratum approach in this trial, is so that we can then bring all of the data together and be able to provide a much larger amount of information on safety, and particularly given this is a new class of drugs, and provide information in a much broader range of patients that have not previously been tested, but even those with diabetes, where we have a reasonable amount of evidence now for targeting this pathway. We don't have the evidence in combination with drugs like SGLT2 inhibitors, and also we'll be able to provide information on what the effects will be in important subgroups of interest as well.
But why don't Markus and Gunnar chime in as well?
Yeah, so maybe from my side, it's one or two suggestions or questions, because I think in many nephrologists there's a wondering about the finerenone now, with and without SGLT2. As you just mentioned, we do not have really the data whether they have an impact together on heart kidney outcomes. There will be a presentation at the ERA in Vienna. I heard it. There's only a modeling from Brendan Noyan, as you know.
This has been published already in Circulation.
Yes, Brendan's already published.
Yeah, Brendan's work, but this is a model. It's not a study. But one of the claims of finerenone was that by its peculiar occupation of the MRA receptor, it exerts, so to say, activation of anti-inflammatory transcription factors, thereby preventing inflammation and fibrosis, in contrast to spironolactone and eplerenone. With your compound and this class of compounds, if they're effective, and I think so, because you showed already albuminuria, maybe they show the same data, this claim will be rejected or annihilated, or?
So take your second point just then. I think it will. I'm not sure what the data will show. We have to do the trial to show that. Whether we'll reject or refute that hypothesis of effects on fibrosis remain to be seen. We're not doing any mechanistic sub-studies in the trial, so we can't answer that question. All that we will be able to answer is whether it has beneficial effects on hard clinical endpoints, whether we stop people developing kidney failure, or whether we stop them from dying of heart disease or having effects on heart hospitalization for heart failure. Certainly from the finerenone data and what we saw in Fidelity, and also the FINE-1 meta-analysis, is most of the effects seem to be driven by, in terms of the cardiovascular outcomes, by reductions in hospitalization for heart failure. So you do wonder or get the suspicion that there must be some cardiovascular remodeling going on, whether that's left ventricular hypertrophy, or whether that's fibrosis, or something else. Unless we have the mechanistics, we wouldn't know that. And I don't say that EASi-KIDNEY would be able to categorically provide that. Going back to your earlier point, yes, you're right. There are other trials ongoing that are attempting to study the combination of finerenone and an SGLT2 inhibitor. The Confidence trial is one such trial, which has recruited 807 participants. But again, it's only individuals with diabetes and CKD stage 2 and 3. So they were looking at finerenone versus empagliflozin versus finerenone and empagliflozin in sort of in 3 groups. But the outcome is only a change in albuminuria over 6 months. So again, we won't see effects on hard clinical endpoints. So whilst it will provide very important safety information, because we, as you say, we don't have that information as yet, and it will give us an idea or an indication as to what the combination might do. Unfortunately, it won't provide a sort of solid kind of confirmatory results. So yeah, we need the big trials to be able to provide that.
Okay, thank you. And then maybe one final question. It's both concerning mechanism and safety. As you mentioned, always with the MRAs, we have this hyperkalemia problem. I don't know whether I can speak for most of the nephrologists, but we think subconsciously finerenone is something like an MRA light. It has only 3 hours of half-life, therefore maybe less hyperkalemia. By blocking aldosterone production, we suspect much more hyperkalemia. What do you say with the available data from phase 1 and 2 trials and about this mechanistical contradiction, so to say?
Yeah, so certainly for, we've seen the same for the EASi, that in the phase 2 trial, the results on potassium, there was an increase of about 2.8 millimoles per litre in potassium. Sorry, 0.33 millimoles in potassium. But that was actually much reduced with empagliflozin, and the addition of empagliflozin made that increase of only 0.28 millimoles per litre. And the meta-analyses, which Doreen showed by Brendan Newen and colleagues, does suggest about a 16% relative risk reduction in the risk of hyperkalemia, although the overall mechanisms of that are unknown. So we hope that the combination of the EASi with an SGLT2 inhibitor will help mitigate that. But yes, it is a concern with this class of agents, and I suspect that's probably why the previous trials have been more cautious in the patients that they've recruited, with a potassium of entry of no more than 4.8 millimoles per litre. In EMPA-KIDNEY, we're going slightly more bolder. We're including participants with a potassium up to 5.2 millimoles per litre, and we've done some modelling that would suggest that combination of the EASi with an SGLT2 inhibitor won't substantially increase the proportion of patients that may be at risk of a much higher potassium of 6 millimoles or greater, and actually the excess risk of that proportion of patients that would develop very high potassium would be similar to the proportions in the finerenone trials. So hopefully the combination with an SGLT2 inhibitor will help mitigate that risk, but again, without a large trial testing that and providing that hard safety evidence, it's difficult to know.
In this regard, maybe final question also to Professor Mann, this new substance class of these EASis or ASIs, I have a lot of patients with primary hyperaldosteronism who can't tolerate anymore this spironolactone and eplerenone due to their side effects, and who can't, due to bilateral hyperplasia, not be adrenalectomized. Do you think this substance class will be a solution for them for the treatment of primary hyperaldosteronism? Maybe we need a higher dose.
Short answer, yes. Not only likely, but I'm very certain.
Yeah, because finerenone doesn't work. Just from personal experience, it's too light, and I didn't want to experience or try 100 milligrams or something like this.
I am involved in 2 of these trials, and I've looked at the data rather carefully. So therefore, I'm certain that they will be very effective in these situations of primary hyperaldo. And I believe also, looking at the side effects, as you said, of the traditional MRAs, that they will be used in these instances. And I also would be interested to see whether in the studies that we have just seen, working on showing the effects in hypertension in JAMA and in the New England Journal, how many of those included were indeed showing signs of primary hyperaldo.
I think many, yeah. Okay, thank you. I hand over now to Gunnar.
Yeah, and I have a couple of final short questions on the study design, and then if time permits, maybe one larger question to Hans-Man in the end. So, but first I would love to add vitamin D and other components of CKD-MBD to those agents that have been tested for decades and that did not have any renal protection, and to my best understanding also few, if any, cardioprotection roles. So I guess that's important to see how trends change in nephrology. But having said that, so coming back to the question from Marcus, why do you go for a single dosage of these new agents after we have very different dosages for traditional and also for novel MRAs? So do you not see maybe the need to up titrate and down titrate the dosage according to blood pressure to potassium?
Yeah, great question. The company has decided on the 10 milligram dose based on the available pharmacokinetic and pharmacodynamic data, and much of that was derived from the CKD population phase 2 trial. And clearly there has to be a risk benefit. And as I only showed you the primary outcome data of albuminuria, but also, in terms of the effects on GFR, on blood pressure, they were much lower with the 3 milligram dose. And then the risks of, hyperkalemia and other effects were greater with the 20 milligram dose, but without very little gain in terms of effects on albuminuria. So the 10 milligram dose is the one that's been selected and the one that's being taken forward in both the phase 3 kidney trial and also the heart failure trial. So, yeah, we are where we are. We're essentially limited, unfortunately, to the 10 milligram dose, and hence sort of that's the dose that's being tested in this trial. There is another risk or concern, a hypothetical risk with these agents, with all of them, not just with vicadrostat, but there is a hypothetical risk of effects on cortisol, and those will be monitored very closely in the EASi-KIDNEY trial, and also I'm sure the other trials of the ASIs will be similarly monitoring that. And it's a slightly curious one because it could potentially reduce the levels of cortisol because there is a hypothetical cross-reactivity of aldosterone synthase inhibition as well as cortisol synthase. So you could decrease the levels of cortisol and end up with adrenal insufficiency, but equally because of the way that you could end up blocking cortisol synthase, you could end up with larger levels of cortisol by sort of rerouting through the corticosteroid pathway. So we don't actually know what the effects will be on cortisol. As I say, we are monitoring this closely in the trial. So far, the studies have not shown any effects. Certainly with the vicadrostat, there was no overall difference in the levels of cortisol over the 14-week period. There was no effect seen in the baxdrostat trial. In the lorundrostat trial, there was actually a small increase in cortisol, but within the normal range, and no sort of effects on cortisol excess reported. And likewise in the vicadrostat trial, no cases of adrenal insufficiency or crisis reported. So I think we are, unfortunately, in EASi-KIDNEY, we are limited to a 10 milligram dose, but I think there are, sort of genuine reasons and concerns why the developers may not be too keen on going much higher, but that might come in the future. Yeah.
The next question, what about patients with heart failure? So surely patients with heart failure with reduced ejection fraction shall not be included because they have a clear indication for spironolactone or eplerenone. But what about patients with heart failure with preserved ejection fraction? And actually, quite a lot of our CKD patients do meet criteria for HFpEF. And now we have the finerenone trial. So how shall you recommend us to proceed if we consider recruiting patients into EASi-KIDNEY?
Yeah, great question. So there needs to be equipoise in the clinician's mind. So it's left to the local investigator. Clearly, if there's a clear indication for an MRA or an ASI, then you should not be entering your participants into EASi-KIDNEY. And certainly, we definitely would not want a clinician to stop an MRA or an ASI if they were on such treatment to enter them into the trial. Now, if there's a clear indication, for example, because they've got heart failure with preserved ejection fraction, if a participant's taking spironolactone for management of blood pressure, then that's a different sort of reason, and then those individuals would be eligible. But certainly, if there's a clear indication, for example, heart failure, then yes, those individuals should not be entered into the trial.
And any ASI on the market?
No.
So as far as I'm aware, there's no ASI on the market, but there are, with large trials ongoing, there's always a chance that, for example, vicadrostat, which has sort of been tested much earlier, may develop a license. Although, having said that, there is a drug called aldosteron, which has a license and an indication for treatment of Cushing's disease. So it was one of the early ASIs to be developed. And sort of results were published in, I think, the Lancet back in about 2015 now. But there were such profound effects on ACTH that actually it was being developed as a hypertensive agent, but it subsequently has been licensed for management of Cushing's disease. So it is on the market, but for a very niche indication.
And patients who are on dapagliflozin are allowed to switch over to EMPAs. Would there be a washout period, or can one just switch over and then include them into EASi-KIDNEY?
Yeah, so another great question, thank you. There is no washout needed as such, and as long as the investigator and the participant are happy for the individual to stop dapagliflozin and switch to study provided empagliflozin, then there's no reason why they can't participate in EASi-KIDNEY. And we're not specifying a washout as such, although once the participant has been screened, the investigator does need to approve that they're happy for that participant to start empagliflozin before they can start it, but we were encouraging our investigators to do that as soon as possible after the screening visit. So there is a very minimal sort of time between stopping one treatment and the other. Yeah.
My last question on the study design. So apparently the renal endpoint is somewhat different from EMPA-KIDNEY, because in EMPA-KIDNEY you also had cardiovascular death, and this is now actually an independent, also co-primary endpoint, but you would have a say more pure renal endpoint here, excluding cardiovascular death with EASi-KIDNEY?
So the endpoint for the kidney part of the composite primary outcome is the same as EMPA-KIDNEY. The only aspect of the composite that's different is now the addition of hospitalization for heart failure. So in EMPA-KIDNEY, the primary outcome was cardiovascular death or kidney disease progression. Here we've got both of those plus hospitalization for heart failure. And the reason for including that is essentially based on the available data that we now have, particularly from the Finerenone trials, showing that targeting this pathway has a substantial effect on reductions in hospitalization for heart failure that were shown in the Fidelity meta-analysis. So given that we know that there is a potential for benefit, we included that outcome in the primary composite.
So it's actually one compound endpoint, not two primary compound.
So no, it's one composite primary outcome of cardiovascular death, hospitalization for heart failure, or kidney disease progression.
My last question goes to Dr. Mann. So with all this evidence, do we still need to measure HbA1c? You told us that there are those glucose-lowering drugs that do not have any prognostic implications. We do have others, like the ones we discussed here. Why should we still try to achieve glucose levels?
Well, there are still problems when you have very high levels of glucose and very low levels of glucose. And this will remain the way it is. And therefore, we still measure it. In addition to that, we were talking here about mostly patients with established kidney disease and diabetes, as far as we were speaking about diabetes. But remember that out there, not in our clinics probably, but in other clinics, there are patients with diabetes who have no signs of kidney disease yet. And they, as far as we know, benefit from metabolic control.
So thanks so much to the three of you. Marcus, we have to continue with Marcus at home for the next years so that we can discuss the results of EASi-KIDNEY, say in 28, 29, nobody knows surely, but I guess at the end of this decade. So thanks so much again. Thanks for starting this study. Thanks to Dr. Mann for joining us. And we would really recommend and ask all our colleagues in Austria and Germany and in all other participating countries to recruit their patients into this study. There are many participating centers all around Austria, I guess, and Germany. So let us help the Oxford team to give us these important pieces of evidence. Thank you.
Thank you very much.